Specialist on call is like having an additional colleague who's always in the emergency room. One of the differences is that as a private neurologist, we might see 6 or 8 patients a year with TPA questions. With specialists on call, there are people who are doing 8 or 10 of these a day, so that we feel that there's more consistency in the patient responses. And so when patients come to the emergency room, they have somebody who's there, who does this all the time, who's confident with us, and then lets us follow the patient up because we come and see them in consultation the next day. There's also the understanding that if a patient gets TPA and has any difficulty, they would call us and we come in immediately.
From the time that rescue pick up the patient and bring them to the hospital, we get in contact with the patient, examine the patient, and then after the CT scan is done, we basically call SOC. And
the specialist on call doc calls you right back. He discusses the case with you. Then he goes on the video camera, talks to the patient, the family, looks at the CAT scan or MRI, and then he calls you back with recommendations and then faxes his recommendations over.
They have somebody who's a neurology consultant anytime. Not just for stroke questions, also if they have a patient in status or a patient with an intracerebral hemorrhage that's clearly an intracerebral hemorrhage, anything that comes in neurological that needs a fast answer, they're there on site.
We're down to just a handful of neurologists trying to cover in-house and emergency department cases. Obviously, they're not very willing or able to come into the emergency department for every TIA, CVA, weak and dizzy patient that we have. So specialists on call fills in that gap.
Particularly after the emergency room physicians became comfortable with them and confident that SOC was giving them good advice, the SOC would write the recommendations and the emergency room physicians administer the TPA, and the SOC physician stays on and watches the patient through that first hour.
They discuss the risks and the benefits with the patient, the family. They do the NIH stroke scale. They figure out the dosage based on the patient's weight.
It's definitely been a positive for our hospital. The Joint Commission was impressed when we went for our stroke certification that we had SOC in place. It's been good for the emergency room physicians who haven't always been as convinced that TPA was good to see a group of people who gives this all the time and watch their decisions being made.
They are excellent neurologists. They are, as we mentioned, very fast in calling us back.
They're very timely. There's always more than one doc neurologist on call, so there's never any delay in getting hold of the neurologist.
One of the things I like about SOC is that no two people always make the same decisions. And so the next day, if I see a patient and I think, why did they make that decision? It's very easy for me to call up. I have Leonard Da Silva's name on my contact list on my phone, and I call him up and say, Len, what was going on here? What was the decision? Tell me the thought process here. So I get it. I get feedback. He gets feedback. We feel like we're building a better process for the patients.
SOC neurology, the teleneurology, has been a big help, and in areas like this hospital that we depend on quickly decide if a patient needs emergency administration of thrombolytics, trying to help and decrease the morbidity and mortality of our patients, decrease the length of stay, improve the care of our patient with a stroke.
For us as physicians, I think we work smarter the next day, not having been up all through the night with a TPA question. When it comes to making decisions in the office, we make better decisions for our patients because we're not trying to do two things at once, being daily physicians for the outpatients that we see, or even physicians for patients that we see in the hospital. If you're well rested, you're going to make better decisions. The patient's going to get better care.
Acts as a great medical legal risk reducer. Having a neurologist see a patient right away, especially when they have the potential to deteriorate during a night before an attending sees the patient, makes us feel much more comfortable sending the patients to the floor. We're a community hospital setting, so the attendings don't come in right away to see the patients. They have up to 24 hours, which kind of leaves us on the hook. But having the neurologist see these patients makes us feel much more comfortable.
There's some possibilities not yet mined, and I think one of them is Specialist on Call has a huge experience, obviously the biggest experience in the country that I know of, giving TPA, as teachers for emergency room physicians and teachers for neurologists, saying this is what happens. Even a stroke neurologist, if they're not doing full-time stroke, they're a community stroke neurologist, is not going to give TPA that many times in their lives. They're certainly not going to give 100 cases or 200 cases or 1,000 cases in a year, which SOC will make that many decisions on TPA. They have a lot to teach us.